Hello, my name is Michael Bass, and on behalf of our group at the University of Texas Southwestern, I will review with you today our presentation titled Raising the Bar: Quality Considerations in Multiparametric MRI and Targeted Biopsies of the Prostate. In this presentation, we will review the role of MRI and image-guided procedures in the assessment of patients with suspected prostate cancer, why quality matters, and what are the factors that influence the quality of images, reports, and biopsies in this patient population. Finally, we will discuss the life cycle of a quality improvement project and share some best practices that we have adopted to measure and improve quality in the context of a prostate imaging program. So, why quality matters? Here, it is worth taking a minute to briefly recap the journey of a patient with elevated PSA. After being seen by a urologist, frequently a prostate MRI is ordered. The patient schedules, prepares for it, and the prostate MRI is performed by the technologist. The images are interpreted by a radiologist, and depending on the findings and the clinical scenario, the patient undergoes a biopsy. So the MRI helps not only triage patients that need the biopsy, but also indicates where the biopsy sample should be taken from. After those samples are obtained, the pathologist reviews the material and informs the ordering provider and the patient whether or not there is cancer. A very important aspect of this loop that is vital to reiterate is that the quality of each step is heavily dependent on the quality of the previous steps, and therefore also influences the subsequent steps. If images are of poor quality, for example, radiologists are unable to provide meaningful information to the referring physician. If the radiologist's interpretation or target annotations are inaccurate, the targeted biopsy will miss cancers. Before we dive deeper into the several elements that contribute to quality in an imaging program, it is important to remember that quality assurance and quality control are two distinct practices, which in turn are balanced by the process of quality improvement. Quality assurance puts processes in place to ensure high-quality images, reports, and biopsies. For the quality of prostate MR image, for instance, this includes making sure that the patient is prepared before arriving, that the scanner has the appropriate PI-RADS-compliant protocol, and that the technologists are familiar with the process. Quality control, on the other hand, evaluates the effectiveness of the process. When the outcomes of this process differ from the expected outcomes, we have to ask, why did this happen? Auditing tools such as patient and staff surveys and standardized measures of image quality like PyQual, which we will discuss later on, can help us determine the reasons for suboptimal image quality. With that information, we can plan quality improvement projects to change the process, and that is a concept that we will get back to later on as we discuss the life cycle of a quality improvement project. Having understood these important definitions, we can then move to the three pillars of quality in prostate imaging: the quality of the images, the accuracy of the radiologist's interpretation, and the biopsy accuracy. First, the quality of the images. Here, we see an axial T2 weighted image that normally is expected to provide a good depiction of the prostate anatomy. We quickly recognize that, in this case, however, the information provided by this blurred image affected by motion is not the same as this very good quality, similar image from another patient. This good quality image shows a small suspicious lesion in the anterior gland that was then shown to be a high-grade cancer. This explains why, expanding on our previous discussion, that high image quality is essential for optimal decision making. So, why aren't all images as good as this last example? The first reason is a vulnerability to artifacts. Here you can see some examples, from rectal air, as you can see in this case, causing distortion of the DWI on the right, then motion, as you can see in these three different patients, resulting in different degrees of blurriness of the anatomy, and metal, such as in this patient with bilateral hip prostheses, with significant distortion of the DWI and ADC maps. One last example that is much less common nowadays since most MRIs are performed prior to a biopsy is the presence of blood in the prostate mimicking or obscuring cancer, as you can see in this pre-contrast T1 weighted image. This brings me to another key point, recognizing that artifacts influence image quality. So what can be done about it? Here is a list of selected interventions. For example, patient education to ensure compliance with the prep instructions and that the patient understands the importance of not moving while images are being acquired. At our institution, we employed the use of a fleet enema and visiting the bathroom right before the exam to reduce the amount of stool and air in the rectum, as well as a few other interventions. But this is not the whole story. This different case illustrates other critical factors to image quality. This was an MRI for elevated PSA done at another facility on a patient with bilateral hip prostheses. In addition to the artifacts from the hips, the imaging parameters were not optimized for prostate imaging. The MRI was read as negative, and he underwent a 12-core biopsy that was negative. Because his PSA kept rising, he came to our institution. A repeat MRI was performed. If you look closer, hopefully you will appreciate the difference in the level of anatomic detail. For example, better discriminating the BPH surgical capsule, and on this exact same level, we can now clearly see a sizable and very suspicious left-based lesion. This patient was then biopsied, and a grade group 4 cancer was found in the cores from that region. This brings us to the next key point, that in addition to artifacts, technical parameters also influence image quality. In this case, the optimized protocol resulted in better images and more reliable information. We frequently hear how 3 Tesla images are better than 1.5 Tesla, but there is much more than the field strength alone, and hearing that a patient had a 3 Tesla MRI may not be a guarantee of high quality images. As our group explored how consistently we radiologists were documenting cases of suboptimal quality in our reports, we quickly realized that we needed a more consistent approach. Consider the first case. Urolift clips are seen on the T2 weighted images, and they have a clear impact on the quality of the diffusion weighted images at the base of the transition zone. In the findings section of the report, a radiologist could note suboptimal quality exam. This could then be interpreted by one neurologist as, well, this is not great, but it's an okay exam, while another urologist may not have time to read the impression. So we have the potential for 2 different interpretations of the same description. This is even more complex because we could have different radiologists, for instance, report that this has degraded DWI images. The first urologist may place great emphasis on that statement, while the other may be frustrated with so many abbreviations. This example highlights the confusion that may arise from the lack of common language and the need for a structured reporting system like PIRADS, which allows us to be on the same page and leaving less room for misinterpretation. As part of the increase in the number of exams, our group went from 1 site and a small group of radiologists to multiple sites performing prostate MRIs read by a larger number of radiologists, further increasing the room for variability. Given the impact of image quality on the clinical decisions, we identified the need to adopt a standardized approach to measure and communicate image quality in our reports. And what is that tool? It is called PIQUAL, which stands for Prostate Imaging Quality Scoring System, and this is a timely conversation because its latest version, version 2, was just released. It is now a 1 to 3 scale, 1 being the worst quality and 3 being optimal quality, covering both biparametric and multiparametric approaches. The first version was developed by investigators from the Precision trial, and this revised version incorporated input from an international expert group. The current version is based on 10 criteria, down from 34 from the original version, with a mixture of objective technical parameters and semi-objective qualitative parameters. This latest version also designates some critical or required technical parameters that, if not met, should cost all points for that specific pulse sequence. This latest version also moved from treating all sequences equally to giving more weight to diffusion and T2 weighted sequences relative to dynamic contrast enhanced sequences, in keeping with the greater role of these sequences in clinical practice. This scoring flowchart illustrates the scoring approach. An exam receiving a score of 1 means that 2 or less criteria were met on either diffusion weighted imaging and or T2 weighted imaging, and it means that dynamic contrast enhanced imaging did not meet both criteria. This indicates that the exam is inadequate, and the recommendation is to repeat the exam. Note that an exam receiving a score of 1 can be upgraded. If, for example, an image meets 2 out of 4 criteria on diffusion weighted imaging, but it meets 4 out of 4 criteria on T2 weighted imaging and 2 out of 2 criteria for dynamic contrast enhanced imaging, it can be upgraded to a 2. Another way to qualify for a PIQUAL score of 2 is to meet 3 out of 4 criteria for both diffusion weighted and T2 weighted imaging. This scenario cannot be upgraded or downgraded by dynamic contrast enhanced imaging. A PIQUAL score of 2 indicates that the imaging is adequate, but carries the caveat that repeat imaging could be considered depending on the circumstance. Finally, a PIQUAL score of 3 can only be achieved if all 10 criteria are met. This indicates that the imaging is optimal. As one can imagine, it is challenging to stay up to date with yet another structured report and the expected regular updates. At our institution, this is addressed by making the latest accompanying references available in our intranet page and by taking advantage of system-wide templates in PowerScribe. These are educational tools to help reduce variability in reporting. Here you can take a closer look at this template with fields and pick lists that help the less familiar radiologist navigate the different criteria in a relatively intuitive way. Now that we have covered image quality, we can move to the second domain of quality in prostate imaging, the report accuracy. In addition to the traditional peer-reviewed process that is common practice in most institutions, the use of MRI information to guide biopsies provides us with rich imaging pathology correlations that are great learning opportunity. This is increasingly supported by benchmarks of expected negative and positive predictive values for each PIRAD score that can be assessed on a per reader basis or for the entire group, similar to what is done in breast imaging with BIRADs. Another rich source of feedback to our group of radiologists comes from cases discussed in the tumor board, as the example shown below. MRI of this patient was initially reported as negative, and a 20-core saturation biopsy did not reveal cancer. However, further review during tumor board discussion indicated a suspicious nodular focus in the right seminal vesicle. Subsequent PSMA PET-CT confirmed the suspicious finding, and repeat targeted biopsy demonstrated a grade group 4 cancer. Finally, the third pillar of quality, the concordance of the biopsy and the imaging findings. This flowchart details our process for reviewing biopsy results based on the imaging findings, identifying discordant cases that may require additional clinical scrutiny, as well as cases with learning points to be shared with the radiologists who read prostate imaging. This is done through bi-monthly RADPath conferences, which is also an opportunity to discuss opportunities for optimizing our practice. The example shown here illustrates a suspicious PIRADS 5 lesion, which initially had discordant grade group 1 pathology on MRI ultrasound fusion biopsy. However, after further review of the case, it was decided to perform an in-bore MRI guided biopsy, which confirmed grade group 4 disease. This example demonstrates the importance of radiologic pathologic correlation. Now, moving on to the life cycle of a quality improvement project. The life cycle of a quality improvement project can be broken down into 3 phases. First, it is important to assemble a diverse team who have different perspectives about the problem you are trying to solve. Your team should define scope of the project, a timeline with deliverables, a method to track and share data, and a SMART goal for your project. The goal should be sustainable, measurable, achievable, relevant, and time-bound to be considered a SMART goal. The second phase is where the improvement happens. We start by observing the current process. It is important to understand what the process is and why it was designed this way before trying to change it. Then we analyze what causes any deviations to the process. Before you know it, the root causes of the problem will start to take shape. Once you understand your root causes, you can develop interventions to solve your problem. This part of the process relies heavily on data collection and refinement. The third phase is where we wrap up the project by implementing a sustainable plan for our improvement efforts. With sustainment in mind, we use this project as an opportunity to record several videos for educational initiatives among our abdominal imaging group, technologists, and urologists. Simply put, multi-parametric MRI and image-guided procedures have become essential in the diagnosis and management of prostate cancer. This is made possible through achieving consistent, high-quality images, which result in accuracy of both reports and targeted image-guided biopsies. Finally, programmatic safeguards and quality improvement initiatives are essential in maintaining this standard of high-quality imaging. On behalf of my group at UT Southwestern, thank you very much for your attention.